Great. Thank you so much, Amy. So I'm going to share my screen and welcome again everybody who is just joining. This is Lisa Letourneau with Maine DHHS, and I'm here with my esteemed colleague, Dr. Stephen Sears, who is the real expert on this. We are, again, recording these sessions. We do, through a very fortunate partnership with the Maine Medical Association, are able to offer half an hour CME for every session that you attend. If you want CME, you must please enter your name and email into the chat. The chat's down on the bottom. If you mouse over the bottom and look around in the buttons, you'll find it. If we don't have both your name and email, we just don't have a mechanism to get in touch with you to do the survey that will be required or the evaluation. So please do that, and we'll be tracking it over the series of sessions, and then eventually you will get an email with an evaluation, and we will send you a CME certificate. Amy, would you mind just muting anybody who looks like a speaker? Thank you. We have no disclosures to recognize in terms of conflict of interest. We also really want to emphasize the need to partner with all of you. We're all learning together. Again, incredibly exciting that we have now these 2 authorized vaccines, but vaccines in a vial don't save lives, vaccinations do. And you are all the key to getting those important vaccines into the arms of our patients and our communities. There is a lot of information to cover. We have developed a curriculum of sorts, and we're going to try to just keep marching through some of these topics. So for those of you who may have been on the session last week, we talked a little bit more about the context, the science of vaccines, and the development and approval process. We're going to talk a little bit again about development and approval, but new information about Moderna and information that's being learned as the vaccine is getting out there. So with apologies, there will be some repetition each time, but we're trying to, again, continue to advance the curriculum, so you'll hear new information as well. I also wanted to recognize that we have several members of our clinician outreach and education work group on the call with us, some great experts from around the state. And again, we are definitely all learning together, so I'm sure many of you have some great information we'd encourage you to share. So with that, and apologies for both of us talking quickly, Dr. Sears.
Yep, great, thank you. So I'm just going to root us back in mRNA vaccines, just as a kind of a refresher from where we were before. On the bottom of the slide, you'll actually see the mRNA vaccine, and that is both the Pfizer and the Moderna. The way this works is you take some mRNA, which it codes for the spike protein of the coronavirus. You wrap it in a little bit of a nanoparticle of lipids. It's injected, it goes into our cells take it up, it goes to our ribosomes. The ribosomes produce the proteins of the spike protein. It gets exuded into the cytoplasm. Our immune response goes, wow, something foreign, let's take care of it. And we make really robust antibodies against the spike protein. Next slide, Lisa. Couple of things, I think it's important to always remind ourselves, this is not a live virus. This is just a little tiny piece of mRNA. It does not go into the nucleus. It doesn't change the DNA in any way. This type of technique for vaccines has been worked on for at least 15 or more years, although this is the first time it's been used. But the safety processes that were used in this are the same ones that are used for all vaccines. It seemed like it was speeded up, and that's because things were being done not necessarily serially, but continuously, so that we got information. And it appears to be a very safe vaccine. So how does it work? Again, there's the lipid nanoparticle. It's wrapped up. The antibody is against the spike, and you can see the spike protein on the bottom. And it was authorized. The first one was authorized December 13th. And the next one was just this past weekend. A lot of people have talked about the safety. I will mention these both appear to be equally efficacious. I'm going to compare the two of them in a minute. But there are systemic side effects. When we say that sometimes people start thinking really bad things. This is really fever in a small amount, but mostly fatigue, headache, and chills. Everybody gets a sore arm. Those are non-specific signs. It does not cause specific signs of COVID. It doesn't cause cough, shortness of breath, rhinorrhea. It doesn't cause a sore throat or a loss of a taste of smell. The side effects appear to be much more significant after the second dose. And the way we sort of look at this, I think, is these side effects show that the vaccine's working. Your immune system is working. So what's the difference between these two vaccines? Very little. One, they're made by different companies, but you can see the differences. The trials were robust with over 30,000 people. The efficacy is almost the same. The adverse profile appears to be the same. The Moderna is given at 4 weeks. The Pfizer is given at 3 weeks. There's a cutoff of 18 years for the Moderna, 16 for the Pfizer. The big difference, I think, is in the shipping and handling, which is the Pfizer requires ultra cold. The Moderna can be in your regular freezer and is much more easy to transport and to break up into smaller doses. Next slide. A lot of people have asked, what's in this vaccine? It's actually, they're both very similar. They're not exactly the same. They contain the mRNA, as you can see the first line. They contain a lipid nanoparticle which coats it, and then there's some salts and sugars. The Moderna vaccine is proprietary, and that's one of the things they were able to do, was to stabilize this mRNA in a much more robust way. So that's why they don't need the ultra cold freezer. But some people are interested in this, because one of the contraindications is if you have an anaphylactic reaction to these components. Most people do not know they have a reaction to these components. They just know whether they're a person who tends to get a lot of vaccine not reactogenicity, but allergic response or anaphylaxis. Because we know that there's this reactogenicity, it's recommended that you have a conversation with someone beforehand, tell them that they may have local symptoms, they may have some post vaccine symptoms, much more so on the second vaccine, where they might get headache, muscle ache, malaise. How much fever is seen in younger individuals? It's about 15% on the second dose, and about 10% in older individuals. That's over 55 to 60. And it's not generally a high fever, but it is worth having that conversation. People who have had significant allergic reactions to vaccines in the past, or they carry an EpiPen, or we need to monitor them more closely. And I'll talk about that in a second. You can take antipyretics. You can take analgesics. It's not recommended to take them routinely, but you can do it. I mean, I want to emphasize, for most people, this is annoying. It may slow you down for a day or two, but it's not that. It doesn't really put people to bed. It doesn't really get them out of work. But as I said, you have to tell people that there really is this reaction. We've all heard that there have been some allergic reactions. The first 2 were reported in Britain. There were 2 reported in Alaska. There have been some reported around the country. It's still pretty unusual, but because of that, in any place we're giving vaccine, we need to be prepared for someone to have a significant reaction and have in place the medications to control anaphylaxis. And I'm not going to go through all that, but you have that on both these slides just to remind us on what we need to do and what we need to have in place for anaphylaxis, which is to be able to respond to an individual should they have a significant side effect. Next slide, Lisa. There we, whoa, that's
sorry. Yeah, so
and so we'll talk about the phase distribution now. As I said, so I didn't want to go lightly over anaphylaxis, but on the other hand, we're not here to teach us all how to manage that. What's needed is written on those 2 slides if you just need a refresher. And I've got to say that in all cases, when people have had a significant reaction, they have all responded well. There've been no as I said, everybody has done well with just minor interventions. So Lisa, why don't you talk about the distribution?
Great. Oh, fine, Steve. Hand it to me when it gets
to the good stuff.
Yeah, there we go. So I said, yeah, fine. Hand it to me when it gets to the hard stuff. No, I'm just kidding. I volunteered for this, actually. So this is part of the difficulty right now, right? We're seeing and hearing a lot of concern about who's next. And we very much through Maine DHHS, Maine CDC are trying to follow the recommendations of the national groups. This is from the Advisory Committee for Immunization Practices, or ACIP, which actually just updated their recommendation on phased distribution of the vaccine this past weekend. So this is from a slide from their meeting this Sunday. And they did actually not change anything about phase 1A, which is to healthcare personnel or healthcare providers and to long-term care facilities. So that is what the plan is right now. That's where we are right now. What they changed was their definition of phase 1B and phase 1C, and then lumped everything else into phase 2. And then there is no other phase. There used to be a 3 and a 4. So we are still very much on phase 1A, as you've all seen. It's been absolutely fantastic and exciting that we've received supplies of Pfizer, and then as of this week, Moderna. Those initial supplies have gone out to hospitals with the intention of vaccinating those most critical to preserving the infrastructure to care for COVID-19 patients, so ICU, critical care, COVID units, and EDs. We have, I think most of the larger hospitals have been able to do that, and now the smaller hospitals are getting Moderna, which is easier, as Steve mentioned, to ship and refrigerate and can be moved around in smaller aliquots. So they are still working on that. And as a department, we are very much still working on the definition of who's next in 1A. As you all know, there are many, many, many healthcare personnel who could be defined as that, but we need to continue to prioritize. This is not a secret, it's not proprietary. We just need to still do some work to outline that. So there will be communications coming soon about who hospitals should approach next, and then how we get this out more into the ambulatory setting as well. So we hear you, we know it's important, and it is coming, but it's going to be a while still to be vaccinating in phase 1A, while the pharmacy partnership works on vaccinating long-term care facility staff and residents. Until we get to phase 1B, which is frontline essential workers, not healthcare, but workers like transportation, public safety, and then to anybody over 75 or 75 and over, excuse me, as well. And then to eventually those younger, but with medical conditions. So it's coming, but we all just need to be patient and wait until we continue to get more vaccine supply. So I mentioned this already. Another issue that Dr. Sears mentioned in terms of reactogenicity also means that because people could develop symptoms that need to be observed for a day or two, there's also a recommendation to vaccinate in waves, meaning don't vaccinate everybody in your ICU the same day, because some might develop symptoms. And that's particularly, again, as he said, true of the second dose. And we very much need to continue to monitor for safety. And we're going to talk about that more and the systems for doing that in subsequent weeks. There's also a lot of questions about, who can vaccinate, where is this going to happen? Right now, it's happening in hospitals, and then again through the commercial pharmacies for long-term care. But there are also going to be efforts for EMS to be doing some vaccinating. Many of you are enrolled and registered in the Maine vaccine program. So some will be happening through that. But again, because of the logistical issues, and now particularly, as Dr. Sears mentioned, the need to observe for and be prepared to treat anaphylaxis, that's going to have some different implications for how this can be operationalized. And then we're hoping to enroll our public health nurses in some of these efforts as well. We have posted this information, including slides. These are all live links. Everything in this PowerPoint is a live link. And those are posted to the Maine CDC's COVID-19 provider portal. I will chat the link. It's not easy to find on search, unfortunately, but again, this link is live. The slides are posted, and it's this yellow circle that if you click into, you'll get to this PowerPoint, and I'm going to chat the link for that as well. So with that, we're trying to stick to our goal of preserving exactly half the time for questions. So I'm going to take off share, and we're going to take questions. And I'm going to ask either Dr. Belisle or any of our clinical staff, if anybody has had an opportunity to kind of be monitoring for the questions. I know it's a little hard to sort out as everybody's putting in. And again, if anybody's joined late, if you're a provider and want CME, you need to put in your name and your email, both of those things, into the chat so that we can track that and be back in touch. So anybody want to, Steve or Amy, start out with a question? I just have not been able to monitor as I'm talking.
Well, I saw one go by, which is easier to answer, which has to do with pregnancy and breastfeeding. The CDC says that it's not a contraindication. Specifically, that I'm sorry, there were no breastfeeding women or pregnant women in the trials, but this is not a live virus vaccine. It should not be a problem. And ACOG actually has a very good statement, which I think we put it up last time, which basically says that pregnant women should not be excluded from trials. They should be considered. And breastfeeding should not be a reason not to have someone get vaccinated.
And I think, Steve, the emphasis both with pregnant women and breastfeeding is just have the conversation with women, right?
Yep.
And then it's their decision on the risks that they want.
And that is what the federal CDC says, is have that conversation.
Mm-hmm. And I'll bring up that PowerPoint and go to those where the slides are relevant. So sorry, I didn't have that up. Others.
Have doses been reserved for the second dose? The answer is yes. And so every time that we are given a first dose, somewhere in a storage area, they're putting aside the second dose. So there will not be a problem with getting the second doses.
One question, Steve, is about standing orders. So do you want to talk through that process so far? This question is specific about assisted living, they've received consent from residents, but they want to know, do they have to have a physician's order for each resident? Do you want to talk just generally about how the standing orders?
Yeah, there is a set of standing orders in the Pfizer literature, and that is, but it should be generally signed by a medical provider to provide this vaccine overall. But if a place we're in the process, when I say that, that's the CDC, of looking into this as we did with the COVID tests and things, but that's not yet ready at this point. And so, Amy, I'm not sure whether you had something else to add to that.
Yeah, I think right now the hospitals are doing their own standing orders. Yep. One of the issues that we have sometimes when doing state standing orders is there can be an issue with some of the Medicare insurers in terms of the billing if it's coming from the state. So hospitals right now are doing their own standing orders. And, right now the billing system on this is that you can bill the insurers, Medicaid, Medicare, private insurers for administration of the vaccine. Steve, another question for you is, can you talk about whether those who have received the vaccine and may have effects in 24 to 48 hours after fever, headaches should be required to receive COVID testing prior to returning to work? Yeah,
there's a very good set of guidelines on the federal CDC website, and the vast majority of individuals who have a reaction do not need to be tested for COVID, but you do need to consider that. So if someone has, for instance, if they had a high fever or they appear to be developing any of the respiratory symptoms, again, the respiratory symptoms are not associated with the vaccine, and that would be much more likely to be COVID overall. But if it's sore arm, a little aches and pains, as I said, there's a good algorithm and discussion of that on the federal CDC website, which we can try to put up I think it's on one of the links on the last page overall. Most people do not need a COVID test. There's probably an in-between group where they look a little sicker, and they have a fever, then you need to be concerned.
There's a question, if I just
Lisa.
grab one here. Can you ensure that clinicians who are not employees of large healthcare organizations will have equal access to the vaccine? So I mentioned in my comments just a bit earlier that there is work going on through Maine DHHS to identify sub-prioritizing within category 1A. So I think it depends what we mean by equal here. Eventual, yes, but we cannot obviously say equal. We can't say if somebody, is doing mostly telehealth right now that they get equal access to an ICU nurse, right? So we have got to sub-prioritize based on, again, the ability, number one, the ability to maintain critical infrastructure to serve COVID patients in critical care settings, and number two, then, relative risk of exposure. So we will be coming out with some more details about that very soon. Amy, others who have screened the questions.
What other vaccines, non-COVID, utilize the mRNA technology, Steve?
There's none that are authorized at this point in time. There has been a lot of work on early on. The work was done with cancer vaccines, but there's also been a vaccine developed, which is still in developmental phase for both Ebola and for Zika. The technology, as I said, the Moderna company has been doing it for a while, as have a number of other places. But this is the first time with given the imperative of finding of getting a vaccine for this for coronavirus that it's come to use at this time. But lots and lots of trials and lots of research data prior to. There was a question went by really quickly. How effective is the vaccine after the first dose? Most people think it's about 40 to 50% effective, but we really do need the second dose to make this a durable immune response. So it's very, very important that anyone who gets the first dose comes back for the second dose.
And I'll just underscore that to say, and that the two are not interchangeable, right? So if you get Pfizer 1, you've got to get Pfizer 2. It is not, you can't do the second one, Moderna, if you've had Pfizer the first time. There's also a question about if folks can, where they can access materials and watch a recording. This one, we also recorded Tuesday last week. So while you take the next question, I'm going to do a share screen and just show people. I did put the link some number of chats ago, so I'm going to put the link again, and then I'm just going to show you where you find it. Go ahead and take the next question.
So Steve, this question is around, the person said that they've read that Moderna vaccine is showing more promise in inhibiting transmission. Have you heard that?
I wouldn't say that it holds more promise. They did more studying of the Moderna vaccine for that very question, and that's a very, important unanswered question completely at this time. But Moderna vaccine, they did do a lot of subsets looking at whether it actually stopped not only disease but also infection, and then stopping infection would then likely stop transmission. And the data is more complete for the Moderna vaccine. I think that both of these vaccines are going back. There's a number of trials that are being extended right now. Both of these vaccines are going into children. Both are looking more at the transmission question. Both are looking at pregnant women. So there'll be more data coming out on these vaccines as we move forward. These were meant to do the high-risk populations and over and across large populations, and including populations with people of color.
Steve, will this be a yearly vaccine? Do we know that yet?
We do not know that yet. If I were to look at any other respiratory virus that we have vaccines against, which the only one we do is routinely is flu. Yes, and so anyway, that it's speculation. How much does it mutate? We just heard about mutations in England. I want to emphasize that the mutation that's in England does not appear. The vaccine appears to be effective against that. There have been other mutations along the way of COVID in the last 10 months in the spike protein area. So this is the change in England is not unexpected. It's just a new mutation, and there's been a lot of news articles about it more than anything else. But more to come on the yearly part of this.
I see a lot more questions around the standing order, so we'll take that back to the CDC. The last time that the standing order came, it came for testing from Dr. Bennett. So I see the questions in there. We'll bring that back to the CDC to talk about that with them. Another question is around how much has this been tested in older patients over 75? And then another question is, if you have someone that has cancer or bone marrow suppression, should they be vaccinated?
The answer to the first one is both of these trials had reasonable, and when I say reasonable, if you look at 30 to 40,000 people, 20+% or more of individuals were individuals over. In Moderna, they said 65. I think it's 55 in the in the Pfizer vaccine, but it was a reasonably sized population, and it appeared to be very effective. If we look at the subset of immunocompromised, there were not enough people to know that, but it is recommended not to withhold this vaccine. And again, they should be, as you can see, the individuals are counseled about unknown safety and side effects, potential for reduced immune responses. And that's probably the biggest, because we always get concerned about that with individuals who are immunocompromised. Will they respond? It is not a live virus. And so therefore, the concerns that we have had before have been, are really not of concern. It's, we know that these individuals are potentially more likely to get severe disease. So we do administer, it is recommended.
There was also a question, and just while I've got this, this is the US CDC slide set, which is also posted to that link that I just showed a minute ago. There was a question about what's the time window for the grace period. So this is for Pfizer. Second dose should be 21 days, 3 weeks, but the grace period, they're saying 17 to 21 days. But then you've got here, if it's more than 21, just administer at the earliest opportunity.
Yeah, but it should be within ideally within a week or so. But you do get more on the back end going longer out.
We've got 3 minutes left, so one question and then we'll need to wrap.
There's a question about, will they get a vaccine card? There is a PDF of a vaccine card.
A little hard to hear you, Amy. I don't know.
There's a question about a vaccine card. There is a vaccine card that the federal CDC has put out that patients should get when they're vaccinated, with also a reminder to come back for the second shot.
Yeah, and I've heard those have run short at some places because of the extra dose thing in the vial. And so institutions just need to print their own and give them to people.
Yeah, I'm pretty sure the immunization program sent out some templates to places that were vaccinating so they could make more copies, because indeed they did run out.
And I believe the app vSafe, which we'll talk about more in a subsequent one, I believe that has a reminder that you can put in there too for when somebody is due again. And they should be scheduling, you should be scheduling the second shot when somebody is being vaccinated.
Correct.
Okay, so actually let's do one more. We got 2 minutes left and then I'll wrap. Most common question, Amy, what are you seeing? I can't even track them all. Priority
It's
questions.
really the prioritization and making sure that groups are not left out of the system.
Yeah, so we don't have a chance to answer every one of these. And part of this is we also, don't have specific answers, but I can reassure you there is tremendous attention being paid to this at the highest levels of the administration, and there will be communication coming out about this soon in terms of sub-prioritizing within 1A. And certainly the intention is to provide vaccine to everybody in category 1A, which is direct contact with patients or contact with potentially infectious materials. So it is just a matter of how soon we can get vaccine to those, and then what's the mechanism. I've heard people or seen people say, what am I supposed to be, how am I supposed to know? That is also a work in progress. I'd say contact your own healthcare provider first. That's going to be the easiest way to do this. And then there will be other settings to get vaccine as well, and more to come.
I would like to say one thing, Lisa, just again to remind individuals, everybody, that we don't have total control over how much vaccine comes into the state of Maine. As you've heard, it generally comes in on a Monday. We've only gotten so far the first dose of Pfizer, just getting the second dose. We got the first dose of Moderna. The second dose of Pfizer was not as much. It was down by 40% as what we had been originally estimated. So the CDC does its best to then run fast to try to make sure that the vaccine that we get will be used most effectively across the prioritized populations. But this is still it's an incredibly successful undertaking, but there are lots of obstacles in the way and lots of changes that what we say today, you may hear that, oh, wow, we got a whole bunch more next week and we can expand things. But I doubt it's going to be that. I think it's going to be more that the vaccine amount is going to be, we're still going to be challenged for a while until at least into mid to late January.
Great. So we are going to have to wrap. I'm going to share one more time my screen. We've talked about where this is available. Information is posted. It is on the CDC website, the vaccine portal. I did chat the link a couple of times. If folks see that, I will leave the line open here for a little bit if people want to go back and find that. And it's this yellow circle here where we have posted the Zoom recording from last week. We'll do it for this week. We've got slide sets. We'll post those. And again, US CDC is just an incredible resource as well. So it will be there. Again, one more time, if folks want CME, you have to put both your name and your email. I cannot figure out names from emails. So again, I'll leave this open for a while. You must put both, and you must put them every time you attend for any session that you want the half hour CME. Because of the holiday, we won't be holding these sessions. Unfortunately, the next 2 Fridays, Christmas and New Year's both fall on a Friday, but we will be back next Tuesday and then on the Tuesday, Friday schedule. After that, we will be again continuing to progress the content with some repeat of some key information and updates clearly as they come out. So thank you, Dr. Sears, Dr. Belisle, all of the members of our clinical work group who have chipped into these efforts, and all of you for joining us and for your work on the front line. So stay safe, have a peaceful holiday, and we'll see you next time. I'm going to leave the line open again to chat in your name and email if you want credit and or find our links. Thank you all. Stop recording, Amy.